Hey, this is Dr. Desai. I'm going to talk a little bit about recognizing EKG changes in patients that have hyperkalemia and how you want to go about treating them. So hyperkalemia is a common occurrence in the emergency setting. Normal potassium levels are usually between 3.5 to 5. Potassium is an important ion as it's fundamental for excitability in nerves and muscles for appropriate functioning. It also dictates cardiac pacemaker activity, and it also helps control the resting cell membrane potential. Causes for hyperkalemia, there are lots of different causes that can cause hyperkalemia. Some of the most common ones, well, it's not most common, but it's something that's very simple. It's mechanical factors. And by mechanical factors, what I mean is if you have a tourniquet applied to the patient's arm for longer than a minute, it's been shown to cause false hyperkalemia. If the patient is clenching their fist while drawing blood, that's also been known to cause false hyperkalemia. Vigorous mixing of the blood after it's drawn into a tube, transporting the blood through pneumatic tubing devices or an unpadded canister, and using an inappropriate needle gauge. Using a smaller needle can sometimes cause hemolysis, causing false hyperkalemia. Medications are also a very big reason why folks can have hyperkalemia, and there's a long list of medications that can cause hyperkalemia. Some of the more important ones that you may see very often include anyone getting a blood transfusion as a risk for developing hyperkalemia, but some of the other ones that can cause it: spironolactone, which is a potassium-sparing diuretic, ACE inhibitors, angiotensin receptor blockers, which are both high blood pressure medications, your NSAIDs, your ibuprofen, your Aleve, naproxens, trimethoprim, which is a common antibiotic used, Bactrim, and then succinylcholine, which can also cause hyperkalemia. Some of the medical causes for hyperkalemia include the most obvious: renal failure, crush injuries, burns, acidosis. So the EKG changes that you want to look for in these patients, you may not see the EKG changes in all the patients. It's important to keep close monitoring over your EKG to look for developing changes. EKG is not sensitive for diagnosing hyperkalemia. You always want to refer to your electrolyte panel or blood testing that actually checks for hyperkalemia. Hyperkalemia causes EKG changes because it decreases the conduction between myocytes and basically causes a prolongation of electrical conduction through the cardiac myocytes. EKG is a very good tool, but you have to remember it's not diagnostic of hyperkalemia. If you have a patient that you ever pick up and you do an EKG and you're suspicious that there may be hyperkalemic changes on there, look for reasons the patient might have hyperkalemia. Does the patient have a history of renal failure and has not been to dialysis? Is the patient on any of the medications that were discussed on the previous slide? Is there a reason the patient would be hyperkalemic? But you don't want to rely solely on your EKG to determine someone has hyperkalemia. If you're concerned that the EKG is showing hyperkalemic changes, what you may want to do is monitor closely with repeat EKGs to see if further changes develop. And the changes that you want to look for, I'm going to discuss next. So, and these numbers are not steadfast. There are patients that can have very elevated potassiums and have no changes. There are patients that can have very minimally elevated potassium levels and they can develop all of these changes. So it's not a hard and fast rule, but this is just kind of as a standard. As you see a potassium level increase above 5.5, that's when the first change you'll oftentimes see is your T waves will become peaked. As you can see on the EKG, all of the T waves are peaked. It's not just in isolated leads, but as a global, all the T waves should appear peaked. The next change that happens as the potassium continues to increase, your P waves will widen and begin to flatten out with eventual loss of the P wave. You may also see a prolonged PR interval or first degree AV block in these patients. And you can see here, this is it's a junctional rhythm. There's no P waves, and you can see it's your T waves are peaked in this rhythm strip right here. As the potassium increases greater than 7, you'll start seeing widening of your QRS complex, and you can also see conduction blocks. You may see a bundle branch block or even a fascicular block. And on this EKG, you can see you've got very peak T waves, you've got widened QRS, and there's complete loss of your P waves. So this is becoming a very dangerous situation here, in which you need to start treating this patient very quickly before they deteriorate further. As your potassium levels get above 7.5, you develop what's called a sine wave. And the sine wave, it goes back to, this is trigonometry, for those of you that remember this from high school days, but they're referring to the sine wave from your trigonometry class. It basically has this wavy form, and if you see that, that means this patient is pre-terminal and is about to go into cardiac arrest. You need to move very quickly on this patient. And then as you get potassium levels greater than 9, that's when your patient is extremely high risk if they're not already in cardiac arrest. And you may see them in asystole, ventricular fibrillation, or they may even have just this very bizarre wide complex rhythm. One of the other rhythms that's also been associated with hyperkalemia is a slow atrial fibrillation. That's also been known to be associated with hyperkalemia. So that's also another rhythm to look out for. So the treatment, the initial focus of treating these hyperkalemic patients is to determine, A, are there EKG changes that were discussed in the previous slides? And if there are, you want to stabilize the cardiac membranes immediately to prevent any life-threatening dysrhythmias. And there's only one medication that will stabilize cardiac membranes, and that is calcium. And whether you use calcium chloride or calcium gluconate, calcium chloride is more bioavailable. However, calcium chloride is known to cause irritation, and it can cause pretty bad necrosis if there's any extravasation. So it's preferred to be given through a central line or a larger vessel access. However, if you are in a potentially terminal event in which the patient is in cardiac arrest or near cardiac arrest, you want to give what you have, and you want to give it over 3 to 5 minutes. And if you don't see any improvement in your EKGs, you can repeat a dose of calcium in 5 minutes. The duration of action on calcium is 30 to 60 minutes. So it's important to remember you continue to monitor your EKGs after giving it. You might see improvement of your EKGs with narrowing of your QRS. Your peak T waves may start to come back down. However, you need to keep a close watch to make sure those changes don't start developing back, as this calcium is not a permanent fix. It's a very temporary fix. You have about 30 to 60 minutes. During this time, it's important to start other interventions to decrease the potassium level, as the calcium does nothing to reduce potassium levels. You must give other treatments to reduce the potassium levels. So the most common one that I think most people use is D50 and insulin. The way this works, insulin stimulates the sodium hydrogen transporter on cells, which stimulates sodium potassium pumps. I know I'm getting very biochemical here, guys, but basically what it does is it helps shift potassium into the cell. So the way you want to use this, you give 1 amp of D50 first, followed by 10 units of regular insulin. That way you avoid any hypoglycemia. Onset is less than 15 minutes, and you get a peak effect in 30 to 60 minutes. This will give you about 4 to 6 hours in which it lowers the potassium by about 0.6 milliequivalents per liter. You want to monitor your glucose after using this treatment. A lot of times, most patients will do okay with the amp of D50. However, in your renally impaired patients, they sometimes tend to become hypoglycemic and further dextrose is needed. So you want to keep a close eye on your glucose levels after you treat with this D50 and insulin treatment. Other treatments that you can consider: albuterol. Albuterol is a beta agonist, and it also helps shift potassium intracellularly. The dosing, however, it's not the 2.5 milligram dosing that's typically given in an asthma exacerbation. It's 4 times that. You have to give a 10 milligram dose, and it will decrease the potassium by 0.6 milliequivalents per liter. Furosemide is also a good hyperkalemic treatment. It helps eliminate potassium by eliminating it through the urine. You can give 40 milligrams in patients with normal renal function. However, if your patient has a history of kidney disease with diseased kidneys, it may take as much as an 80 milligram dose to see any kind of effect. Onset is within 15 minutes. The duration will be 2 to 3 hours. The one thing to remember, though, is if you have a dialysis patient that does not make any urine, furosemide will not be effective at all, as they will not be able to diurese any potassium out of their system. Other treatments that can be considered include K-exolate, which is also a potassium eliminator. It binds potassium in the colon and completely eliminates it. However, the problem with K-exolate is the onset is not until 2 hours with a peak effectiveness of 4 to 6 hours. So in the immediate emergent setting, which you need to emergently reduce a potassium level, K-exolate may not give you immediate results. However, over a longer period of time, there may be some effectiveness to it. There is one small caution to take with K-exolate, however, is it has been known to cause bowel necrosis. So you want to use this with caution in any patients that have ileus, bowel obstruction, are on opioids, or potentially have other underlying intestinal issues such as ulcerative colitis or C. diff infections. Sodium bicarbonate is also a medication that's been known to treat for hyperkalemia. However, it's not been proven to be very effective just used as a monotherapy, but it does have good adjunctive therapy in patients that have metabolic acidosis. And of course, your definitive treatment is hemodialysis in your patients that have renal failure and significant hyperkalemia. So that's the basis of treatment. You want to go with your calcium first to stabilize your membranes and prevent the patient from deteriorating into any kind of deadly rhythm. Insulin D50, albuterol, furosemide, and then bicarbonate if available, and consider K-exolate in consultation with your nephrologist. And so that is a quick summary of recognizing hyperkalemic related EKG changes and the treatment. If you have any questions, please feel free to comment below in the comment section, or email me, or please come see me in my office. Thank you very much.